You've got a wonderful brochure. Does everyone have one of these? Did you grab one coming in? It's going to be useful because I'm going to not waste our time because we have a lot to do tonight by doing long introductions. So I'll give the brief one, and if you want to know a little more about each of us, please look in the pamphlet. By process of elimination, you'll figure out that I'm the woman pictured here, and really proud to be the Dean Emeritus of this school and currently a professor in this school and the Geffen School of Medicine. So we'll get to that. This is our last forum of the year. I'm just curious, how many of you come regularly? Can you just give me a quick show of hands? Terrific. It's been, for those of you who know here, a highly successful series, been going on for years now. We usually, we cover lots of topics. This has been a boring year, obviously, but going from the evolving Affordable Care Act to issues about workforce, and tonight to who knew there were politics and health policy, really. So there we go. Let me, before we get started, thank some of our sponsoring partners. First, the Beaumont Foundation. Ed Hunter, its CEO, is going to be speaking and presenting the premier documentary here. The UCLA Center for Health Advancement, co-directors Jonathan Fielding, who I'll introduce in a moment again, and Fred Zimmerman, and of course the Fielding School of Public Health. Also want to thank Jennifer Scott. Are you in the room, Jennifer? I can't even find you. Are you out there working? So Jennifer Scott is a lead for this event and in our development office. She's got a fabulous staff, and they really make this event terrific. So I want to just thank everyone in the development office for getting it. Okay, so we do have a lot to do. We're going to, we have a great panel. So what I'm going to do now, just to keep the flow going, is I'm going to introduce our three panelists up front, and then we're going to see a film, and then our panelists are going to talk some more, and then we're going to open it wide for Q&A, both for the audience here as well as for the online audience. So if you're online, please go ahead and think about your questions and post them. So let me start, not in alphabetical order, but I have to start with him, with Fielding of the Fielding School of Public Health, Dr. Jonathan Fielding. You probably all know about him well, so I'm going to make this a little more personal. He's obviously an active professor on our faculty. He's been a leader for decades in public health. I think if one were to write the history books about leaders in public health departments and were to look at his long tenure as the director of the LA County Department of Public Health, people would appreciate what a truly spectacular and impactful run he had. But for all those wonderful things he does, he's got a special meaning to me personally, to the other faculty at the school, to the staff, and to our students. He had enormous confidence in the school when he and his family were very generous in guiding our future and giving us the transformational gift that named us. And I used to say that a lot one year, but it's been a few years since I've been able to say it. So I just wanted to say it again because it really is pretty spectacular. So we're going to hear from Jonathan. We also have a visiting professor of urology at the Geffen School of Medicine, Dr. Rick Boxer. As you can see, he's had a long history of leadership roles, both in his profession of urology, but also at the federal level in healthcare, including serving on the National Cancer Advisory Board. And finally, who will lead off now, Edward Hunter, the president and CEO of the Beaumont Foundation. It's a foundation that's committed to strengthening, transforming public health, small order there in the U.S. And I had the opportunity to know Ed when we both were working in Washington, D.C. He had progressive leadership roles in CDC, including the National Center for Health Statistics, and until his most recent job served as the director of the CDC Washington office, where he got to see everything. We're going to now turn it over to Ed to go ahead, introduce our documentary, and we'll take it from there.
People hear me? Yes, I can hear myself. Exciting to be here. I'm really looking forward to the discussion. I think it is more timely than I think any of us really imagined, particularly certainly talking about politics and public health is timely. Talking about the Surgeon General in this context, right on the heels of, I think since it was scheduled, the previous Surgeon General having been fired, I think might make something of a point about the intersection of politics and the Surgeon General. I came out feeling like I needed Wi-Fi on the airplane because you're missing the news. We're all sitting here, and it's okay if you look at your devices to see what the CBO said today, or what the president said today, or what the Hill is reacting to the president's budget today. So there's a lot going on, as Linda mentioned. I'm particularly happy to be here and having spent the day in the institution named for my friend Jonathan, who in his own right is an institution. And what I haven't said to Jonathan is a year or so ago, I think Jonathan, who is a founder of the Big Cities Health Coalition, the big cities had a recognition of his role in founding it. It had a button that each of us wore at a dinner, had a picture of Jonathan with a WWJD, what would Jonathan do? and I took that back, and it sits over my computer. So every day when I go to work, I have a little Jonathan, what would Jonathan do? And I probably don't do it, but I at least aspire to doing that. So it's an interesting time to be exploring the intersection of politics and public health, and I think the foundation has a real interest in this because we're a private philanthropy, as Linda mentioned, dedicated to working on public health, and our view is that policy is among the most important tools that we can use, and then in many ways is underutilized, not here in LA County because of Jonathan and others, but I think across the US it's really not something that is understood as well as it should be. It's not used as impactfully as it can be. I think this documentary is part of our effort to highlight why policy is important. Our City Health Initiative, if any of you have seen that, cityhealth.org, a little advertisement. And Jonathan, again, was a member of our Blue Room panel. But I think we're really anxious to stimulate and perpetuate a discussion about how policy can be used as a public health tool. And clearly you can't do policy without engaging with politicians. And I think that the tendency of public health people to shy, or science people in general, to shy away from the engagement with the political system has held us back from being as impactful as we might be. So this documentary, I'm just turning to that, is built from a 2007 House hearing on the Waxman being ranking minority counterpart, looking at the history of the Surgeon General and political meddling. And I think we developed this into a course, and then in the process of doing that, got some updated commentary that you see in the documentary to sort of reflect on that hearing, but also broader events. I'll note Brian Castrucci and Adam Judge at the Beaumont Foundation really were drivers of this and might be out there watching on the web, and so they deserve a lot of credit for respondents of credit. To me, this is about the Surgeon General, to be sure, but it's also about this bigger question of how do we engage the policy process, sort of the messy world of political process. And facts, truth, the evidence are really important, but I think the history of the Surgeon General and others shows that it's not enough to just simply stand on facts and evidence and not understand some of the the spoiler alert, I think, in the documentary, truth is not the only ingredient in policy making. There's a lot of other dynamics, and if we don't really understand that, we're not going to. And then finally, I think on the Surgeon General, I'm looking forward to the discussion of the panel. I think all of our officials in public health, anybody in a science-based field, has to be held to a high standard of not sort of caving to political, while being aware of political situations. I think not caving to them, sort of standing for the truth. But I think though all of the people in the public health realm and the science realm have that standard, I think the Surgeon General has a special standard that I think we've come to expect, and I think it's interesting to see how that plays seeing the documentary, come back and talk about where we are today with that. So with that, I'll turn it back to you.
Politics and public health, two essential ingredients in improving the health of the nation. Two perspectives, at times conflicting, on how to best move forward. The Surgeon General can be an important part of the nation's health system, serving as a voice for health for the nation, and serving as a reliable source of credible health information for the public and policymakers. Through the media and in definitive health reports, the Surgeon General can help translate complex scientific information and focus the nation's attention on critical health issues. To be effective, the Surgeon General must be able to speak the truth, even when it conflicts with the agendas of political officials. For this reason, the Surgeon General is appointed to a term that is independent of a presidential administration. But this does not mean that the office is immune from political pressure, and the history of the Surgeon General holds many examples of clashes between public health and politics. At its best, the Surgeon General has had a hand in saving countless American lives. However, Surgeons General have also struggled to preserve the essential independence that gives them their credibility with the American people.
I think I can sum up the intent of the Surgeon General in its job description: to protect, promote, and advance the health, safety, and security of the United States. Real simple on paper. But when you try and execute on that in a very hyper-partisan political environment, it becomes treacherous.
The Surgeon General is the doctor to the nation, a uniquely trusted figure who brings the best available science on matters of public health directly to the American people.
We need to discuss the importance of keeping the Surgeon General independent and free to communicate directly to the American people on disease prevention and health promotion.
The public expects that a Surgeon General will be immune from political pressure and be allowed to express his or her professional views based on the best available science. But when the science-based views of a Surgeon General are marginalized and ignored, that essential independence is lost.
The voice of the Surgeon General can be a powerful antidote to societal ill health. It should not be muted or filtered through layers of needless bureaucratic or political approvals.
I think if you go back to the earliest possible days of the office of the Surgeon General, there was a lot of meddling.
The office of the Surgeon General has always been challenged, okay? And it's changed over the years.
Just go back and look at Walter Wyman and San Francisco and the plague, the influence of the business community on whether or not the Surgeon General could call a quarantine.
This position emanated from the Act to Care for Sick and Injured Seamen in 1798. Surgeon General had absolute authority then. If you look back at all of the history, they were the chief medical officer. But as you start tracking it forward, you start to see more attempts at, well, why don't we let one of our guys go run this part or that part? You start to see that even though it's a uniform service, and that was the intent of Congress, politicians are reaching in early on, but not with the egregiousness they do today, and kind of just jimmy-rigging a little bit. Then we come to the late 60s, early 70s, where the Assistant Secretary of Health position is created, which is a politician who will oversee all of the enterprise. The political appointee who oversees the uniform officers.
The relationship between the Assistant Secretary of Health and the Surgeon General over the last 50 years has often guided the successes of each Surgeon General. Failure to build a strong relationship has made it at times difficult for the Surgeon General to enact his or her duties.
I think that we should think of politics as a tool like we have any other tool. There is a science called political science. We need to get much better at it.
Being both Assistant Secretary for Health and Surgeon General generally helped me in terms of navigating Washington, if you will. Having both positions obviously had more authority, more quote power, more resources than if I had been only the Surgeon General.
I think one of the things that we don't do as often as we need to is build relationships before you need them.
I'm more of a Lincoln-esque approach. You want a team of rivals. You want the person that's going to tell you that the emperor doesn't always have clothes on, that maybe there's a better way to do this based on the science. And again, the Surgeon General doesn't make policy, but you inform on policy, and because you're such a credible person, you know, it scares people sometimes. But we should herald that. That's what a democracy is all about. You know, politicians can shade the truth left or right, you know, and all the issues that you hear, whether it's abortion or global warming or all of those things. But the Surgeon General should come in and say, here's the best science we know today to help you all who are elected make the best decisions.
The White House refused to support federal legislation for funding of needle exchanges. It was an example of when it was difficult to be both Assistant Secretary for Health and Surgeon General. As Assistant Secretary for Health, I was expected to support the administration's view. I was a part of the administration. As Surgeon General, I was supposed to speak directly to the American people based on the best available public health science. So it allowed me to leave that office that day and go out and talk about the value and talk about the research that we had done showing this. And my understanding is that many localities and states then provided funding for needle exchange program, and many still do.
There's a difference between the politics at the national level and the local level in many ways. I remember as both a city health commissioner in DC and then of course at the state level, there was a much more feeling of ownership of the policymakers in the community. And I felt, regardless of what political side on an issue people were or what political party they were, you could go in and have a real confidential discussion with them because there seemed to be a lot more ownership of the community. At the national level, it's much more dispersed. And so you have politicians who may not necessarily have ownership of the community, but they have ownership of an issue. And it makes it more challenging at the national level.
It is a judgment of the committee that cigarette smoking contributes substantially to mortality from certain specific diseases and to the overall death rate.
The Surgeon General's report is perhaps the most well-known aspect of the Surgeon General's duties. By speaking frankly to the American people, Surgeons General like Luther Terry, whose landmark report linking smoking to lung cancer was released despite the opposition of powerful tobacco interests, and C. Everett Koop, who broke ranks with a conservative administration to begin a national dialogue about HIV/AIDS, demonstrated the power the office can hold. When releasing certain controversial reports, it is up to the Surgeon General to be politically savvy to get the scientific findings out to the American public.
When you have a Surgeon General's report, it has to be vetted. So people at HHS look at it, people at the Department of Defense, people at the White House, and they send it back to you. And so where we made some very emphatic statements, we'd have remarks like, well, can't you change that word? That's a little too harsh. And I say, well, no, it's not. It kills. It really does kill. Yeah, but you have to say it that way. Yeah, death is death, okay? So, but people try, because of their particular vantage point, who they represent, the special interest groups are calling the White House and saying, you know, you can't let that go out. It's unfair. You know, it's really not as bad as the Surgeon General says. And I'm not saying it. I'm the spokesperson for all of these researchers who have devoted years of time to help us put this report together to affect health policy.
Our recommendation, of course, was that the administration support federal funding for needle exchange. Well, the decision of the White House was not to support those. They never said, you guys are wrong about the science. They just said, you know, we made a decision not to support it. The decision of the White House was not based on the same thing, the decision of the Surgeon General.
The Surgeon General should lead in the areas that the Surgeon General has chosen as his or her areas of priority. I also think that the Department of Health and Human Services has to support the Surgeon General much more in that mission. And we've had times when there's been an enormous amount of support, and we've had times when there hasn't been support. And we've also had times when we've had a Surgeon General who has politically wise and very crafty. And C. Everett Koop, of course, is a role model for that, and learned to work the system, so to speak, to improve the public's health.
He had very strong scientific support for what he wanted to release. There was some friction within the administration. We don't know how strong it was. We only know that he was ultimately able to send letters to the homes of all of the American people talking about this disease. And he said in it, I know it's not easy to talk about how one gets AIDS, but we must do it. He found a way within the context of what was supposed to be a conservative administration to get that out. And I would describe my experience in a very similar way. You know, not that I was supported by the White House in everything that I did, but finding a way based on the best available science to get the message to the American people.
The Surgeon General should always strive to tell the truth based on the best science, because the Surgeon General is not there to appease either party. You're there to bring the best science forward. So whether it's stem cells, abortion, guns, all of those hot topic, volatile issues, tell the truth.
You're going to have political meddling in any job, right? There's always office politics. And I always talk about the fact that medical politics, you go to an academic center, health center, those are the most vicious politics that I've ever seen. We could teach those folks on Capitol Hill a lesson in politics in academic health systems.
Obviously, I think we need a strong person in that office. I think we have one in the new Surgeon General, Vivek Murthy. And I think different surgeons general have been strong in various ways. I think Dr. Benjamin was strong in implementing the prevention agenda component of the Affordable Care Act. And I think that was important. Now, you know, what Congress did was to take the money. There's no defense against Congress deciding not to put money in the budget. They couldn't change the fact that there was a prevention agenda which Dr. Benjamin had developed along with her colleagues, but they could take the money away.
There'll always be political meddling, but we want the position to be protected, that you can't be marginalized because you give an opinion contrary to, say, the administration in power. The examples we use is Federal Reserve or the Supreme Court. They can say what they want, and they're in there, okay? And you may upset the political power that's there, but this is the way I interpret the law. The Federal Reserve, they comment on monetary policy, okay? It may upset a sitting president or a senator or congressman, but nothing happens to them. Their budget doesn't get cut. They don't get marginalized. Why is the Surgeon General different? Why is the health of the nation not as important as all of those other entities?
It's clear, if you work in an institution, people are going to try to drive your agenda in terms of things that you do. And for some of that, you've seen people say, well, that's where the political process is. So when the Surgeon General is not allowed to talk about women's reproductive rights or climate change or those kinds of things, that's a muzzling that occurs. And I don't agree with it, but that's going to happen in the institution, and Surgeon Generals have got to figure out how to get around that. Koop was able to do that with HIV/AIDS. I've not seen any evidence that the Surgeon Generals have compromised the science base of their message, although people have tried to control the messages or the topics that they talk about.
Even the appointment and confirmation of the Surgeon General can be the subject of partisan debate, leaving the office vacant for extended periods of time.
Dr. Koop, as you well know, while I was initially very skeptical about your nomination when President Reagan put it forward, I was wrong, and I've come to know you as a professional dedicated to the public good and public health. You had the courage to speak truth to power and the good sense to distinguish public health from politics, and I learned to admire you and to enjoy working with you over the years on tobacco, on HIV, and children's health.
First, let me say that Dr. Murthy's confirmation process was difficult. As I said to Dr. Murthy when he was struggling with his confirmation, just because your confirmation is difficult doesn't mean that being Surgeon General is going to be difficult. In some ways, it's going to help you because you've had to work through a lot.
And it was interesting when I spoke to both sides of the aisle, especially on the Democratic side of the aisle, with senators that I knew, many of them did not know what the process was. Many of them were not aware of the public laws that talk about how the Surgeon General evolved and why it's a uniform position and all of that.
There are many different officials in the federal public health system, and though they all work together, each plays a distinct role. Many are charged with implementing the president's agenda, and administer programs established and funded by Congress. The Surgeon General is the only official whose term appointment is independent of a presidential cycle, and is therefore in the best position to speak to the science independently of political agendas.
I expect to have continued political meddling in a democracy, but the person that's telling you the truth based on the best science on that day should not be marginalized or discriminated against.
Politics is a part of public health. We like to pretend like it isn't, but it is.
Make sure it's budgeted appropriately, and make sure that the person is relatively protected so that when they render an opinion that might be contrary to ideology or politics, that there's no repercussions for that. Surgeon General, we appreciate your opinion, but we're going to do something else. That's fine. That's the political process. So that's what I think would be best for the American people and the world.
I don't think the office is in trouble necessarily because there are frictions between the Office of the Surgeon General and the White House. There have always been, there always will be. If the White House begins to stand in the way of the science, the public health science, then I think the office is in trouble.
I don't think the Surgeon General has lost being the top doc. I think that on issues that when they rise to prominence, people want that trusted voice. I think that each of the Surgeon Generals in their own way for certain agenda items were the trusted voice.
I believe that there is a dynamic relationship between the Office of the Surgeon General and the rest of the administration, including the White House. I think basically it's a healthy relationship. As I've said many times, it is the responsibility of the Surgeon General to speak directly to the American people based on the best available public health science.
We're not the Surgeon General of the Republican or the Democratic Party. We are the doctor of the people, of the nation. And just as we treat our patients, we have the biggest practice in the world now, over 300 million people, and we have to always evaluate the science and give opinions as to what is best for the greater good of the nation and its people.
First, want to, on behalf of everyone, thank Ed for your leadership in getting that documentary made. Some of the statements we will discuss have been challenged since its production, but now have an opportunity to actually, before we're going to go and open it up to all of you, I'd like to ask first Jonathan and then Rick to make some comments. You're going to go up there.
I'm going to go up there.
He's going to go up there. Dr. Jonathan Fielding, our first.
You know, I think this issue of politics and the Surgeon General is greatly overstated. I mean, after all, the Surgeon General has a term that's not, it's overlapping with the presidential term, and supposedly it's a term appointment, and nobody is going to do anything about that, right? Oh, yeah, I forgot. Vic Murthy was fired soon after this production was made. It's not because of this film, for which I think we really need to thank the Beaumont Foundation, Ed Hunter. They've done a wonderful job in producing this. But it's very clear several things. First of all, the Surgeon General's role has been reduced over time. There was a time when the Surgeon General and the Assistant Secretary for Health were the same person, not in the very distant past, and therefore the Surgeon General was in a position to implement some of the things that he or she thought were important, because it's, in many cases it's an action agenda. But unfortunately now it is really, there's not one national spokesperson. If you look at, for example, issues that are time sensitive, take a look at anthrax or Ebola or whatever. it's generally not the Surgeon General who's talking. It's a different person. It's somebody from NIH, it's somebody from the Secretary's office, it's somebody else. So the role of the Surgeon General, I think, has been significantly diminished. And in some cases it makes sense because they're experts who are dealing with changes day to day and things like an epidemic. But unfortunately, it means that the Surgeon General is increasingly limited to doing reports, which is important, on a bunch of issues, and I'll come back to how those issues are chosen, and speaking on those issues, but in a constrained way. This is not a broad responsibility. What does the Surgeon General do? Well, the Surgeon General waits for there to be a strong body of evidence, and then focuses on, has to be a major disease or illness or injury. It can't be something that is the fancy of just the person involved. And to focus on topics where there are possibilities for change, policies, programs, and system change. And it's interesting, the Surgeon General is not independent. The Surgeon General has a very small staff, and the Surgeon General can't do any report without getting the support of the broader Department of Health and Human Services, because there are people in some other part of that organization that have to really be the major writers of that report, the major developers of that report. So you're constrained in that sense. You can't even think about doing a report if you don't have support from above. That is from the Department of Health and Human Services. So the Surgeon General is increasingly dependent on others. The Surgeon General also, as my view, has at least three kinds of challenges. One, to counter bad or covered up research. The issue of mercury in vaccines linked to autism, for example, that was in fact false research. That was before we had false facts. Secondly, there are ideological disagreements. So the availability of assault rifle sales, of large magazines, or bringing guns into the school, those are ideologic issues, and you know the Surgeon General is not going to be allowed to talk about those issues even when there is a strong body of evidence. And then there's a challenge when you talk about something like the underlying determinants of health, we know make the biggest difference and could do the most to try and reduce the inequities in health, that people would say, you're off topic, that's not part of your charge. If you start talking about housing or transportation or tax policy, economics in general, classism, racism, not your job, Surgeon General, they would tell you. So the Surgeon General is very constrained in talking about the things that are most important to improving health in the future. I think what do we want in a Surgeon General? Well, we want somebody with broad credibility based on devotion to science-based evidence of causation and of remedies. We want somebody who is politically savvy. It's really critical. You have to be canny and savvy. You also have to be selective in choosing the right battles. There's some issues which unfortunately are non-starters. So, but on the other hand, there are times when you have to be a truth teller, even if there is not a consensus within the government, either the executive branch or the legislative branch. You heard about the issue of harm reduction with needle exchange, or the issue of abortion. We're talking about medical issues here. You can't do that. What you have to do, though, is to choose then the few battles that you think are winnable, which means you're going to wind up with a report and you're going to have broad support for that. But you also need to not acquiesce to the edits that everybody wants to make. You have to negotiate those. And it's rare that you get the flexibility to say, well, I'm a Surgeon General, I'm going to put this out. No, it has to go to the White House. Has to go to the Department of Health and Human Services, has to go to other departments that might have an interest in it. So once again, you're limited to that degree. I was asked by the Secretary of Health and Human Services in the last year to do a report on the response of the Department of Health and Human Services to the Ebola epidemic. And when I negotiated, I said, I'm only willing to do it if I don't have to accept any edits. which did not make them happy, but they agreed to it. So what happened was, instead of me having edits, they decided to release it the day before the 4th of July weekend, so nobody would pick it up and everybody was on vacation. So there are more than one way to deal with an upstart. So what do we want in the Surgeon General? We want somebody with broad credibility. We want somebody politically savvy, won't acquiesce to edits, and I think also does the job like he or she doesn't need it. That's absolutely critical. You have to be able to say that the issue and the credibility is more important than any one person or any one term. And I'm not sure that that's understood by everybody when they go into the job, but they certainly learn it fairly quickly. My last comment is you need to be economically sophisticated, because I think increasingly in the future you have to talk about investment, you have to be able to talk about return on investment, you have to talk about the IRR, you have to be able to talk about the cost effectiveness, the cost per quality, and unless you start doing those things, there's a whole group of people that say, you know, you're just kind of talking about health in the abstract. You're talking about things which are not feasible or not practical, and therefore you're really out of step with what's going on. I would say particularly given some of the recent events and recent political events. So that doesn't mean the Surgeon General is unimportant. I would not want to diminish the role that Surgeon Generals have played, but I think it's up to all of us to try and strengthen that role and support it. And that person is a public health leader, not the nation's doctor, because there are a lot of people who could say they're the nation's doctor, but is a very important voice for truth and for justice. Thank you.
Thank you, John. All right, I'm going to ask Dr. Boxer to maybe make a few comments before we have a little more discussion among the panel.
Well, thank you very much. First of all, it's a real honor and pleasure to be with people who, on this panel and in the audience, that are truly interested in the public health, and to be sitting next to an icon in public health. So it's a singular pleasure for me to be here, an honor. I can speak towards and about what it actually is to go through the process of being the Surgeon General of the United States. I was a finalist in the Clinton administration in 1997 and also in 2001 in the Bush administration, being the only American in this hyper-partisan world of being nominated, or I should say being a finalist on both sides of the aisle, which of course means I either have 100% credibility or none. It's hard to say. In any case, I certainly learned what it was like to go through this political process, not being a politician. I'd been very much involved in national politics, had been a senior advisor in the Clinton and a couple of Clinton runs, and also for Al Gore. And so when I was being interviewed or was discussing the opportunity of being Surgeon General when I was in the White House, I was talking to a good friend named Goody Marshall, Thurgood Marshall Jr., who is running this process for the Clinton administration. And he said, now, I want you to know that the Republicans are going to vivisect you. They're going to embarrass you. They're going to destroy your credibility and embarrass your family. But don't take it personally, because they really don't care about you. They're just trying to get at Clinton. Furthermore, it wasn't maybe a perfect fit to have a urologist being nominated for the Surgeon General during the Monica Lewinsky issues. So I may have had that against me as well. Furthermore, finally, I didn't have a ship captain's beard. I was asked if I could grow one to see whether I could compete with David Satcher or C. Everett Koop. I couldn't do that either, and so therefore I became, not always a bridesmaid, both for the Clinton administration and also Bush. Furthermore, when I went through the process and I had an interview, a long discussion with Donna Shalala, who is a good friend for many, many, many years and still is, she was talking about health policy, and what I thought about one thing or another as it applied to the Health Security Act, which I worked with Hillary on or with years before. It was very much a policy discussion. When Tommy Thompson was interviewing me for as he was Secretary of, and to his great credit, in my belief, is that he wanted to reach across the aisle and have a Surgeon General who would be on both, understand both sides of the aisle and the politics and, of course, also the health policy. And so the first question I got from when I was in his office, and it was from his chief of staff, was, who are you going to vote for in 2004? I said, did you ask Norman Mineta, who was the Secretary of Transportation at the time and the only Democrat in the cabinet? Did you ask him that question? And of course, I said I would never do anything that would embarrass the president. I would quit before that. But that was the atmosphere at the time. It didn't really matter what my health policy version or thoughts were. It was more who I was going to vote for, which actually became rather ironic because Richard Carmona, who actually carried guns in the emergency room and was a horrific in many respects, but he fit the Bush administration better. He ran as a Democrat when he left the administration for Senate of Arizona. He came in about 8th out of 7. But the point is that he had a conversion at the time. So and also when I was working through the Senate, different discussions with senators when I was going through in the Bush administration, finally got to the West Wing, where I was told, because I wasn't there, that Karl Rove said no, then he dropped the F-bomb, Democrat is going to be in this administration. And so, where do nominees or maybe good ideas go to die, they go to certain persons' offices. So I certainly learned about the politics and what it's like to go through the process on both sides of the aisle. Some people interested in policy and other people interested in politics. I think that the position of Surgeon General would have been, for me personally, a singular honor, and I would have done as best I could. And a reason why I was potentially going to be chosen is that they look for different things in Surgeons General, and what could you, as a person, be like the poster child for? Would it be like guns in emergency rooms, or in my particular case, I was a 3-time cancer survivor, and I could speak towards what it's like to be a patient as well as a doctor. And that was an appealing part. I must say, I didn't want to go through cancer 3 times in order to be the poster child. I'd rather have seen the movie. But in any case, it would have been appealing because if I can do it, you can do it, that sort of thing. And if I can survive. And also, although it wasn't particularly beneficial or maybe politic to be supportive of the pharmaceutical industry, I was alive because of the research and development of pharmaceuticals by the pharmaceutical industry. So whereas I wasn't particularly enamored with the insurance industry, where I don't think if the insurance industry were to disappear tomorrow, anyone would be sicker or healthier. But the pharmaceutical industry does have some benefits. They may overcharge. They may spend $1 million a day on lobbying, but they still do some good. And so it's, in many respects, the crown jewel of the healthcare industry is the pharmaceutical industry. So, there were certain things that I could speak towards on a very personal basis and identify with the patient very well, having been on both sides of the desk or the bed, whatever, for the bedside manner, realizing what it's like to be on one side as well as the other. And so,
Rick, I'm going to ask for you to take a break here because I know that we're supposed to be moving on. So
pardon me.
I want to get a chance. No, that's great. Love you sharing the stories, but I want to, we've made a few allusions to Dr. Murthy's firing. It happened within days or a week of another firing that obviously drowned out the attention to it. But those of us in the public health community were shocked and disappointed for the very reason that your film demonstrates about the term. He's not the first person that's been fired, but I'd like to maybe ask Ed, since you've thought about this and written about this a lot, and ask Jonathan to weigh in as well. I'm curious if you were surprised about that, and if so, and or not, and if maybe you could explain what your thinking was when you heard about this.
This was, I think, tactically a surprise, strategically maybe less of one. I think, in some ways, nothing is surprising anymore. So I think that's part of the general reaction. So I think there's a couple of things in the context that are. One is the Surgeon General is not a political position per se, neither is the FBI director. But there is a presumption that constitutional prerogative of the president controls the executive branch and has the authority, despite terms and other things, to assert their will on who is serving in different positions. So from a technical legal point of view, I think it's puzzling. It's like it's an interesting, why would you do this kind of thing? It was surprising. It's probably arguably controversial legally, but it seems like no one's going to contest it. I think it calls the question, though, on what is the position of any administration that does this on science generally, on public health generally. The Surgeon General is a key person in the public health realm. It's certainly the one who people think of as being unassailable when they speak on an issue, because they're not heading an agency, they're not in a policy position, controlling money, doing the administration's bidding. So it's sort of one of those last backstops of truth and credibility. So I think it sort of calls the question now, what else do we see in the appointment? So who is this? Who else will speak? If there's, my concern more broadly is when the time comes, and I think it's when, not if there is a health emergency, that a public health official has to step forward and speak to the American people, get a vaccine in the H1N1 pandemic, leave New Orleans in the face of a hurricane predicted. There are a lot of times when you need someone to be credible. Anthrax, when we had Tommy Thompson saying they thought it was somebody who got it from hiking in the woods. Well, that diminished the credibility of the Secretary's office. So there has to be someone somewhere that the public will believe. So I think in some respects it ups the ante on every other appointment that is now made, including the next Surgeon General. And you have to worry that if they're willing to dispatch a Surgeon General who hadn't actually said anything particularly controversial or crossed the administration's policy positions in office, what happens next? And I think that really raises the bar to me for, and I came from CDC, of course, but who's the next CDC director? Is it a really credible public health person? Will the public listen? Will they be interfered with in the face of, not even just ideological differences, but, how do we get facts out? Who do people listen to? And I think that was my primary reaction was, well, if that tree is falling, how do we make sure there's a forest that stands up? And so in some ways that means other public health people, people in county and city and state health departments have to sort of take some of that role. If we can't turn to a single person in the federal establishment, who else steps up and who fills that void, and it falls on a lot of other people.
All right. Well, thank you, Ed. I know, since I know a number of people in the audience, we have a really talented and thoughtful and experienced audience. So I think with just about a half hour left to go, what I'd like to do at this point is open up to the audience Q's and A's for our panel. Again, if you're online, please feel free to use the link to ask a question. And let's see if we have. And we have microphones wandering. All right, I see a hand. You just let us know who you are. I think that would be terrific. Thank you, whoever's going to be asking questions.
Ray Soto. I work in Department of Epidemiology. I was hoping any of you might share your views on the detrimental impact of religious influences on the work of the Surgeon General.
Wow.
Linda?
I'll talk about that, sure. I mean, no, I have a feeling that there's more to your question. You know, one of the things I was thinking about, because I'm still an optimist, and I've certainly been worried about, I think, the very anti-science approach of many in this current administration. But I was still shocked. I didn't think it was a smart political move, but no one cared, so I guess it wasn't stupid that they would sort of go so early against Murthy. But I was trying to think a little historically, knowing the film. I mean, and you capture a bit of it, but Joycelyn Elders, do some of you remember her? She was the Surgeon General, appointed by President Clinton, and then fired by President Clinton. So it's not that, and interestingly, if you remember, some of you remember what happened? I mean, the conservatives were very much against her. She was a bit of a free thinker about sexuality and other issues. In fact, I think she went down on a pretext, as often happens, because she was asked a sort of a public health issue. She was asked in an AIDS conference whether she thought masturbation should be taught as one of many strategies to deal with the epidemic. And she actually said, you know, I haven't thought about that, but, you know, it is part of human sexuality, and maybe that's something that should be taught, but we're not even teaching children the basics. Well, the next day after that happens, the headline in the Washington Post, and I was there to read it, was, you know, Surgeon General advocates masturbation teaching, you know, and blah, 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 blah. What had gotten her really in trouble, though, there's a point to get back to your question, was that she had actually taken on the Catholic Church on their role against abortion and family planning. And so I think the abortion clearly a third rail, and unfortunately now linked inexorably to family planning, which should be very different, I would hope, except for some people of faith who do link the two. But I think there have always been hot button issues, which gets back to Dr. Fielding's point about picking your battles and how you say it and what you say. But I think we're going to find it harder and harder for folks to be raising these issues, and I see a hand at the back.
My name is Stephen Gallegos, and certainly the Surgeon General sets the momentum, the mantle for public health in this country. But to what extent does the local public health officer have as far as his purview to either exercise the limit to what the Surgeon General is advocating for, or to actually take that to another limit in order to have an effective policy towards his public that he's serving in a local situation?
Well, no one better than Dr. Fielding to tackle that one.
Well, ironically, the local public health officer has a lot more running room, if you will, than the Surgeon General, because as the local public health, there's two roles actually. One is the head of the department administratively, and the other is the health officer, which comes with a bunch of legal authorities. And you do have the ability both to put out things you think are important on various health issues, not as constrained as you are federally, but also you're the go-to person when there's an emergency. So you can develop a persona in the media and try and develop trust by talking about routine things, so that when there's a real problem and people have to make decisions, you want to be a trusted source. So the local public health officials has a greater capacity to influence the public than generally the Surgeon General, at least for that jurisdiction. Now, if there's a lot of people talking, one of the things we haven't talked about is whoever's talking, when there's an emergency, there are always a lot of other talking heads. And so there's so many ways you can influence the media, as we're seeing in Washington, that one has to be very careful about what you say, and you have to, in fact, be almost available 24/7 to drown out some of the other forces that are probably not as positive.
I just add, I think one of the things that strikes you about the current environment, the Surgeon General has always had influence, but it's been a long time since they've had power.
Right.
And I think a local health official has more control or power over their defined issues. And we're in California, which is not going to listen to a federal official in a health emergency or in much of anything else. And you can, depending on where you come from, you can argue whether that's a good thing or not. But I think there's also a general societal thing where there isn't a single voice on anything. We're listening to our own networks, we're following our own people on Twitter, we understand our own science, and we choose, we're selective so we're going to choose who we listen to based on who we believe is credible. And if you're in LA and it's Jonathan or Barbara, you're going to listen to who you think is telling you the truth and telling you actionable, important information. And in the current environment, whatever party controls Washington, it's really, to me, more likely that it's going to be local or state that you're going to listen to, because they're probably viewed as being more aligned with what's important and relevant to you as a community.
There's a perfect example of that, and that is when David Thatcher came out for needle exchange, but the feds, the decision by the Clinton administration was that they didn't want to take that on. However, in local governments, the needle exchange programs were used. So that's a perfect example of the local being able to have more power, let's just say, than the Surgeon General.
Well, of interest, however, there were several people on the board of supervisors who were the 5 most powerful people in the county, both legislatively and administratively. They have 2 branches of government who were not very happy with the idea of harm reduction and needle exchange. And it was very difficult for me to get through that. And I was able to, after a year or 2 of trying, by a variety of techniques, but it was not easy. And just because I said that the evidence was clear and I put out information, that was not convincing several of the supervisors.
And it was, we can acknowledge, it was one of a few things that President Clinton actually lamented after his tenure was over, to say that that was a mistake. And I think it was in part because of the credibility that Secretary Shalala and Surgeon General Thatcher brought to the science behind the issue. Looking for more questions. We're going to open this more broadly because this is really about politics and public health. It's through the lens of the Surgeon General, but certainly many of these same issues come up in public health now. Tony.
Well, first of all, thank you all for coming. I'm Tony Schiff. I teach health law here at UCLA. I'm a health lawyer. What I would like to know is, Dr. Fielding, you brought up social determinants, and Mr. Hunter, you've talked about the political overlay. Was it Dr. Murthy's? I mean, like most people, I was stunned that Dr. Murthy was being removed like that. Was that because of his advocacy of allowing physicians to speak to patients about guns in the house and generally about the impact of weapons on the public health? Was that something that was in your knowledge? Because there's very little in the press about what happened, and if you know, I honestly don't know. I don't know.
Would you like to?
And you're the closest.
I don't think we know. I don't think I've heard. I've not talked to people who know. I've not asked. I don't have a conversation with them about this. I think you can probably trace the beginning of the end for Murthy's tenure with his appointment when he was associated with that administration. He was an advocate for the Affordable Care Act, and he had been politically active on the Democratic side. And I know from people who are going through, as you mentioned, the litmus tests that are applied even for Surgeon General, people who are going through the process now for different jobs in this administration are really asked a loyalty test. So I think if they had a holdover, even though it had a term, and they felt they had the legal authority to do that, I don't think it was a single trigger. I think it was probably something that dates back to, wait, who is this guy? Why is he still here? Why do we have to have somebody that we know was on the other side? Personally, I would have loved to have seen the end of any Surgeon General's tenure to be, I'm making a stand, I'm making a statement, I have an issue, I'm going to go out on this issue, say what I think, if it's guns, if it's something else, whatever side you're on, you would be much more comfortable with the position, the long-term good of the public health system for the Surgeon General to resign after or be fired after having done something more dramatic. But I think this was probably simply, this is not a person that was viewed as being part of the
Jonathan, do you
administration.
wanna
Well,
add to that?
more than, I mean, I agree with everything that Ed said, but in addition, he was very active politically before he became Surgeon General. So it wasn't just somebody who happened to vote Democratic. He was very active in the campaign. He was very active in support of the president, of Obama. So I think that, you know, and he had political interests, and he had an organization that was very strongly political. So I think that all those put together. Remember that it took over a year to get him even appointed. This was not, you know, slam dunk. This was a kind of a grueling wait before he was appointed.
And I would just add, I think, first of all, Tony, I think the guns issue is prominent. That was certainly the obstacle to his confirmation initially. Very active pro-Obama. And the third thing I'll say, because I don't know how much White House attention this got at the highest level, but I expect at the vice president and the secretary level, this is a man who is fiercely strong advocate for women's reproductive rights. Planned Parenthood was one of his biggest advocates in his confirmation. And I think that alone, again, we're speculating, but that alone could have disqualified him given what else we're seeing.
Yeah, I think that that he was literally and figuratively in the sights of the NRA.
Yeah, I think that's absolutely right.
Yes, we have another question here. And again, love you to introduce yourselves, please.
Yes, I'm Wendy Lazarus, longtime advocate for kids. With an eye toward the future, and because you all and a lot of people in this room have a fair amount of access to different people, I'd like to hear briefly from each of you, given the environment we're in, what are the one or two issues that you think a Surgeon General, again, someone who could be appointed by this administration, could usefully focus on?
Well, I think that mental health issue is a very important one, and I think the opioid issue is a very important one as well. I think those are two that can be focused on where you can make some headway, despite some of the budget information that would suggest there's not going to be as much funding for those as we had expected or should have been available given the Parity Act. But I think those are two issues that resonate with the American public. Almost everybody has somebody that they know well or a family member who has a mental health problem. Opioids are a terrible epidemic that is ruining families and you know, killing as many people as traffic fatalities. So I would think those would be two good opportunities.
Rick?
I think Jonathan's 100% correct, but I don't think it's going to happen. Not in this administration. I think that what will probably happen is the Surgeon General will come out of the pharmaceutical industry, just as the ASH position, the Assistant Secretary for Health, was just nominated from the bio industry. So in this administration, I think that that those issues which are, I think, critical that Jonathan just described may not be very important to the White House, and they'll talk about other things, whatever those other things are. If there's so much data and so much information and so much opportunity to have an impact on truly important public health issues, I don't think it'll happen.
I'll agree with both of my colleagues, but I think there's also, I guess this would be more of a hope. I think there is a role for the Surgeon General to play to sort of help educate policymakers, the population, about the intersection of medicine and public health. Talk about social determinants of health in a way that we're probably not getting through very well. I think when you think about the opioid epidemic or even mental health, I think the Surgeon General has a chance because they're probably going to try to avoid a lot of hot-button topics. I think there's an opportunity for a discussion about how you broaden from either the medical model or how you incorporate this broader discussion. And I think it doesn't have to be political, although when you're talking about social determinants of health and equity, it brings you into classic role of the Surgeon General is to try to raise the bar in the education.
Yeah.
I think there's also an issue of language. So all of us in this room probably think that the overriding issue for us is to improve health equity. When you say health equity to most people in Congress, I think that it doesn't get the kind of reception one would hope. Whereas you talked about differences or disparities, maybe there's a better chance. But we have to be very careful in the language we use, and I think we need to test with trial communications what resonates. It's consistent with the broader agenda.
Yeah. Did I see a hand up? Let's come down here. And I'll just add, because you asked each of us, I want to second Ed's point. I think there's an opportunity for that discussion, whatever language. I think language is important. And now that we have increasing evidence of income inequality, which seems to bridge a bipartisan divide, not the solution, but the recognition of the problem, if you look at the base of supporters, as an added determinant of health in addition to SES and its more traditional forms. I think there is an opportunity to bring that forward.
And I think it just add to that. I think opioids may be a bridge into that discussion because it affects a population that is not commonly used as the leading example of an equity issue, yet it's based on social and economic forces that I think are becoming more discussed. So there may be some Nixon goes to China kind of thing where a Surgeon General appointed by a Republican administration can help us bridge that.
Well, it also brings, as you said, medicine and public health closer, because one of the real issues in opioid is that we're not giving people effective treatment. The social model is still overused and can't be the only answer. So both on the treatment side and on the prevention side with broad distribution of naloxone, you have medical issues as well as public health issues.
There's a large number of people who voted for Donald Trump who are definitely impacted by the opioid catastrophe for this country. And so he hasn't really gone to that population in other things such as his tax policy or taking away health insurance from them or taking away their food stamps or other things. But maybe he'll say that it's a good idea that we at least identify the problem and try to do something about the opioid problem.
I think we had a question delayed.
Right,
Sorry.
yeah, so Kathleen West, and I am a graduate of the Fielding School ages ago, but work actually a lot on the opioid epidemic on a state-based issue around actually neonatal abstinence syndrome and actually thinking about all politics being local. And who would have thought, that states' rights issues may become where we really want to go. To the point of mayors or governors being a place where we can actually influence public health, I wonder what you think about that as a strategy for working with not only our counties, but at our state levels for moving through and just one by one. I've been in, 25 states this last year on the opioid epidemic, and it's very much at people's tip of the conversation. So I wonder what you think about a strategy at that level.
Ed?
Well, I'm from Washington, and my main answer would be save us. If you're from a city or a state or a county, show us the way out of this morass. And I think that's the history of public health, is that the cities in particular have in fact shown us where to go next. We have our initiative, City Health, is basically based on things where the evidence base came from cities across the U.S. The Community Preventive Services Task Force that Jonathan and the Community Guide is based on a compilation of evidence that comes from cities or states. There's really very few of these things that are done at the national level that you can then book and say this works. So I think the political activism part of it is really key, because there are only, the country has shrunk in terms of where the opportunities are to actually implement things, take the political risk where the political will exists to move forward. And I think we need to take full advantage of that. and then be systematic about how, as public health people and advocates, we collect up that evidence, disseminate it, and use it in evidence-based reviews. A really tough question to answer. I mean, I think all politics is local. I don't think there's a single strategy for how to take back or flip legislatures, but I think to the extent that the public can be made aware of, I mean, I'll back up a step. I think the discussion of the Affordable Care Act, repeal and replace, the CBO scoring that Linda mentioned coming out recently, I think there is a public conversation going on about what are the real impacts of policy choices that are on the table. I don't think I lived through the Affordable Care Act and worked with the Hill on a lot of the public health pieces of that. I don't think there was ever a public discussion about what it really meant to do things the way the Affordable Care Act did them. There wasn't a discussion of that until it started to be on the table for repeal. So I think there's a moment here where you can actually use this to go beyond the specific provisions of the Affordable Care Act and talk about the rest of the public health agenda. And I think voters are going to have to take some role in this. And I think people educating voters will help. But I think it's whatever limited opportunities are left, and I think cities are a great place to start. There are still a lot of cities that are really ready to do things and move forward because they realize that everything else is driven. Preemption is a challenge. There's a lot of challenges, but I think you've got to take the opportunity.
I just want to add one thing in response to Wendy Lazarus's question. I think there's a potential opportunity to work on kids. We have Ivanka Trump, who is obviously committed to family leave and perhaps other things. And if you can, somehow or other, you can get on a bandwagon and broaden what she's talking about. It seems to me that might be something that would have some traction within the administration.
I'm just looking to see it. Here we go. We have two hands. We go 1 and 2.
And I have a question about the role of the Surgeon General in the regulatory process. I mean, everybody's looking at what's going on in terms of changes in regulation. Almost horrifying to see what's going on. But the Surgeon General's office has always been sort of quiet about changes in regulations. And it just seems like this is a time when, if it's not through the Surgeon General, but there are other ways for us to begin to, especially in academic public health, to really talk about the potential impact of these regulatory changes on the health of the public.
I don't think there's any control or impact the Surgeon General can have on regulation.
No, I don't think so. I think, again, the job is a smaller job than it was, and there was a time when one could say, yes, that would be one of the offices you'd pass things through, not now.
Although I think it's fair to say if someone has credibility, and even though we've had changing stature and dual Assistant Secretary of Health Surgeon General roles, which give you a little more power than single ones, that there's still the opportunity as a credible voice to talk about the science behind a regulation. You can't do the regulation, but you can talk about the science. And in this administration, as we're seeing the unraveling of regulations at a pace never seen before, and it's one of the many things that are getting done. We're all talking about the things that aren't getting done, but the regulatory unraveling is quite real, using a lot of sleights of hand. If you had a committed person who could talk about the health effects, of which there are many, and they're mostly environmental and worker at the moment, I think that's why you want that voice until they get, I'm with you, until they get fired for speaking out, but as opposed to just fired. Yeah.
Can I just add one quick thing to that? I think this is that issue of power versus influence. I think the Surgeon General has no official standing in the regulatory process, hasn't through any administration, but to the extent that there is that they have standing within the administration on something like the tobacco deeming around e-cigarettes, you would like to think that if we had a Surgeon General that had some measure of independence, they'd be talking publicly about why that's a bad idea to take back the direction that the FDA is going they might get fired over. Or they may not agree with that because you may have there's lots of issues in e-cigarettes, but it takes a person to put in that job that's willing to, as you said, that doesn't need the job, and then they have to pick. There's only so many things they're going to take on. I think there is a role for influence, but they have to go into assertive.
I would just make one other, excuse me, one other point, and that is, if you think about the discussions we're having about health nationally, it's all about the Affordable Care Act, the replacement of the Affordable Care Act, health care costs, et cetera, et cetera. Health policy, we're spending 17% of our GDP at least on medical care, sickness care. That's all terra incognita for the Surgeon General. You don't see a Surgeon General who feels comfortable, at least not in recent history, talking about those issues, even though that's where 97% of our dollars are being spent on the healthcare side. So already you have a marginalization, which is fairly complete.
I think I'm going to do the prerogative of the chair and take our last question from the last row. That's you, Bryce.
Student here at Fielding. It's to my understanding that Jared Kushner is actually fixing all the problems we brought up here tonight. But actually, on a serious note, so listening to you guys, one of the main problems with the Surgeon General role being compromised by politics is the voice of science in policy in the sphere that we're speaking of. Is there an opportunity for universities to look into different avenues, public-private partnerships, or working with new avenues to disseminate some of the information from city-based policies, from county-based policies? Because obviously the public is not getting this, and a lot of times we're kind of touted as the ivory tower. Are there ways for us as master's students, PhD students, as universities as a whole to kind of improve the narrative created around all of this?
Great question from a student from a great school. Why don't we, I'm going to go in sequence and ask Rick and Jonathan and Ed to comment on that. And then we'll
Sure. Just very briefly, I think that if the Fielding School were to disseminate the students throughout the 50 states and but seriously, the bright minds that are in here and throughout the country in colleges and universities were to go out and be advocates for public health, and the voices will eventually be heard. Maybe not in the next 3.5 years, but in the future. And if you think about that, even in the last year, even research for Zika virus couldn't get through the Congress by the Republicans closing it down. Having these children with microcephalic syndrome being political pawns for the Republicans in Congress is in my mind repulsive, repugnant, and any other word you can think of. So I believe that the future of healthcare will be bright because I'm an optimist, because there are young minds and young people that will go throughout the country and make sure that happens.
Well, I'm very encouraged by the fact that there is so much interest in public health. In every university and every college, you see more and more students studying public health. So I think there's going to be more and more people who can, in fact, be part of coalitions that understand what we're talking about. And this is the greatest increase in public health interest I've ever seen. So that's very positive. And having people, talking to people every day at the school, I can see the leaders of tomorrow, and they're not going to just take this sitting down.
Right. Ed, would you like to add?
Almost time for you to stand up.
Just 2 quick points. One is, I'm actually really enthused about not only what master's level students are learning, but the idea that there's so many people coming into undergraduate programs, to me is not necessarily a public health workforce pipeline. To me, it's a voter pipeline. So if we could get every undergraduate to take a couple classes in public health, then when we're talking about how do you infect other sectors with public health concepts? If you have people who are now working in the transportation industry or the banking industry that have some understanding of public health, maybe we've got a basis for a dialogue. I think that's something I think really that universities can help with, is to not just teach people that are going to work in public health, but teach the next generation, to get a little civics into this, a little bit of why public health is important. And then the last point I make is, I think that in your question was the premise that politics is interfering, or I forget the word, with the Surgeon General's office. I really want us to flip that conversation to not just for the Surgeon General, because they really are supposed to be fairly neutral and unbiased, but I really want to flip our conversation to how can public health people be better at engaging in the political system, not avoiding, not worrying about influence or interference or expression of science, but gaming how we can take our science and our message and our important things and get them into the political system where the real power and the real important.
We need more contagion.
All right.
There we go.
Well, with that great last comment, I want to thank our panelists.
Thank you. My pleasure.
I also want to thank, you've been a terrifically attentive and engaged audience. I know we have some audience online, and just want to let you know that the reception space will continue to be open for a while if you'd like to continue the conversation. Thank you.